What's that? What's your exam tomorrow?
Patho.
Patho. Okay, so, and then you have another patho next week?
No,
Health assessment next week and then the week after. Okay, so let me make a couple of announcements. First off, if you notice, some of you may have noticed your grade suddenly changed on exam 2 today, right? I'm assuming for the better. So when we did some item analysis with Professor Wilson's class, they did not answer some of the questions the way that we had hoped they would. It's kind of, probably material I more went over, so we felt we needed to give those points back. So some of you may have benefited from that. Some of you may have already chose the correct answer, so you would not have benefited from that. And I'll go through them and I'll show you those questions. Like I said, we always do the item analysis. You saw my announcement this weekend that today at midnight is, well, 11:59 is the withdraw date. So if you are all thinking about withdrawing from the course, you really need to make that decision. If you don't think you're going to be successful in reaching the 72% on the 5 exams, then that's something you really, you might want to consider. Those of you at 72, at 70, I think that's recoverable. I think that you can go up when you look at your weighted total. Again, you know best the type of learner you are. When we're talking about 66, 64, that's going to be a little bit harder to recover from. So you might want to, or anything below that, so you might want to consider, again, think about how much time you have to put into the class and the other things that you have going on. And take a look at the policies and how that works for you as well. I'm more than happy to answer any questions. It's a little tough to do it via email though, so I'd rather talk to you in person. After class tonight, I'll go over exam 2 for anybody that wants to stay, and we can go through it, and you can see the results. You can see how you answered those questions to help you for exam 3, because the content does ramp up. The content going forward is a little bit heavier when we're talking about arterial blood gases, alteration in oxygenation, alterations in cardiovascular. It's going to be, the information's a little bit more clinical decision making, okay, that you're going to have to think about. Again, but it'll always be the same format with 50 questions. Ms. Wilson is going to, Williamson is going to do the lecture on pain today. She's prepared the PowerPoint. She's going to do the presentation as part of her student teaching. I'm going to be in the back, so we'll be doing it. She will be preparing some test questions with me. We'll take a look at those and make sure that they're going to be appropriate for this class. And then afterwards, I'll do a little bit of what my expectation. I know that sleep rest is an independent study. But I would really kind of want to give you a guideline of where I'm expecting you to take a look at that, so you're just not all over the board with studying sleep rest. And before we get started, though, I just want to know any feedback from clinical. I didn't hear anything, so I'm assuming no news is good news. But was it a good day for folks? Was it a bad day for folks? Everybody? A lot of anxiety with that first day, getting into the clinical setting. But no problems. You all found where you're supposed to park, where you're supposed to go to, and everybody had a good day. Okay, great. Well, I'm going to turn it over to Ms. Williamson, and I'm going to sit in the back of the classroom.
Great.
Oh, let me turn my phone off, because that would be rude.
There I am. I'm recording. I can see myself. Can everybody hear me in the back okay? Good deal. All right. So thank you, Professor Hanifin, for introducing me. Some of you have seen me throughout sitting in the back of the class or met me in the skills lab. I am here as part of my end of my master's degree for nurse educator, and this is one of the requirements for my class is to film myself giving you guys a lecture in your class. So this is part of my grade, but I'm preparing you for something that you're going to get graded on in your next test. So this is recording, the microphone faces this way, so unless you want to be on camera, just stay back there. I'm also going to be passing out. I'm going to start them around now. I'm going to pass out some index cards. I'd like you all to take one and pass it around. These are going to be something that at the end of the course of the class today, if there is a question that, or a fuzzy concept that you just did not understand, write it down on that card, put it up here, and we can kind of gather together and see if there's a large consensus of something that you guys just didn't get. But of course, I want you, just like Professor Hanifin, I want you to ask questions. I'm going to be asking you questions. We're going to engage in a conversation. In some of our previous lectures that we've been talking about, the subject of medications and pain has come up. And this is a big topic, and a topic that you're going to face every day with your patients. So this is a really good topic, and or something that you guys really are going to need to know about. So just a little bit about myself. I got my bachelor's in 1995, and I practiced for 5 years active duty in the Air Force. I've worked in the emergency room, med-surg. I have experience in labor and delivery, and I also have experience with orthopedic surgery, so sports medicine, and some joint replacement. So when we talk about pain, I think I've seen it. We're also going to be taking some attendance at the end. We're going to be taking attendance for Professor Hanifin, where you write your name, but attendance for me, it says at the top, just your initials for privacy's sake, okay? So, here are the objectives for today. Like we said, we talked about the meds and as it relates to mostly to pain medication administration, but today our focus is going to be on understanding what pain is, the different types of pain, and we're also going to discuss the pain experience across different age groups and populations, and we're going to review some of the non-pharmacological pain management. This guy looks like he's in pain, right? So what is pain? Pain is a complex physiological and perceptual phenomenon, but because it's really subjective and personal, it's an experience that's difficult to define, and it's also difficult for you guys to assess. Now, remember that the subjective data is what the patient is telling you. So what you're getting from them is really what they say it is, and that's the essence of what this quote is saying here. That pain is whatever the person says it is, and existing whenever the patient says it is. This is really the hallmark statement about pain. You're going to see this in a lot of your literature about pain. So remember that it's subjective and personal. So if you saw the title slide for the presentation, you saw pain as referred to as the sixth vital sign. And that is because it is as important as the vital signs that you're taking. Just as you would not neglect taking a post-op patient's temperature, you wouldn't want to neglect assessing their pain. Their temperature is going to tell you something about their post-operative status, and their pain is going to tell you something about their post-operative status too. And studies have shown that adequate pain control improves the rate of recovery, it decreases healthcare costs, and it also decreases post-op morbidity. Assessment of pain is also a standard of care that is monitored by Joint Commission. Do you guys know what Joint Commission is? So it's the accrediting body that's going to come to your hospitals. When you guys are nurses and they're going to come around and it's a big inspection, that's one of the areas that they really assess is, are the nurses monitoring and evaluating the patient's pain? Now when patients have pain, there is a physical response. There's also an emotional experience. A patient's pain can interfere with their job. It can interfere with their social activities. It can cause them to withdraw from their family, lack of sleep, and even an inability to perform their activities of daily living. Now we have on here is pain warning. So is all pain bad? No. So you're working really hard, hunched over your computer. That's how I am. I'm studying. I'm hunched over my computer. My back starts to hurt. That's my warning. Time to get up, time to walk around. So here we have the physical types of pain. So physical pain can be classified as either nociceptive or neuropathic. Now, nociceptive pain is the most common, and it occurs when the pain receptors respond to a stimulant that is potentially damaging. Now, those stimulants can be thermal, chemical, or mechanical. The stimuli could result from trauma, or surgery, or inflammation. Now, can someone tell me an example of a thermal stimuli? Burn, exactly. So, sunburn, out in the sun. How about a mechanical stimuli?
Somebody punch you.
There you go. Let's try to avoid that. How about a chemical one? This might be a little bit harder. Bleach, yep. So there's the internal ones and the external ones. I thought your textbook gave a really good example delineating these two. The chemical one for the external was like that, like with bleach, like a chemical on your skin, like having a paper cut and like cutting a lemon, getting some lemon juice in that paper cut. The internal one, they related to some of the chemicals that are released when you're having a myocardial infarction. So those kind of irritants as causing the pain for the myocardial infarction. Next up there I have somatic pain. And this is pain that is diffuse and scattered throughout the body. It can come from tendons, ligaments, bones. You can have visceral pain, and that's poorly localized. It'll mostly come from your organs. The other type of pain is the neuropathic pain. And now there's some people that are going to argue with you, like my husband, who's a nurse practitioner, and say there's a third category called psychogenic. But your textbook delineates the two, so we're going to stick with the two today. We're going to talk a little bit more about the neuropathic pain in a few minutes, but for now, I just want you to note the difference between the neuropathic and the nociceptive. The neuropathic is more complex and more chronic. The causes of the neuropathic can be the low back pain and diabetics that are poorly managed. And now this is the area, kind of that crossover area between the neuropathic and the psychogenic, and that's the phantom pain. Has anyone ever heard of that phenomenon before? So, this is when you have an amputation of a limb, and the person still feels pain, even though that part of their body is gone. In my last rotation, working with a nurse practitioner in a vascular clinic, we had several patients that had amputations. Some of them had sensations of pain. Some of them would describe it as, you feel like a breeze is blowing across your foot or something like that. So the literature on phantom pain, they're really not sure what the source of it is. Sometimes it's a confusion of the severed nerves from the amputation, but sometimes it's from the cortex that used to process those messages. So that leads us to how the messages travel around. So here we have the physiology of pain. And in nociception, there are 4 interdependent processes. We start with the stimulus, which is transduction. We move on to signal transmission. That leads us to pain perception, and then pain modulation. Now we won't go too deep here, but I wanted you to see a bit of the process. So we start there with transduction. The noxious stimuli is introduced down there. Somebody's poked them on the finger. And we've already discussed the mechanical, the chemical, and the thermal stimuli. The stimuli activates the nociceptors, and now most of the nociceptors are located in the skin. The least are in the internal organs. So next, that pain message gets transmitted to the central nervous system. And that's through some special fibers. You either get a fast message, like touching a hot surface, you're going to draw back really quick. Those are through those myelinated fibers, those ones that are insulated, or the slow messages, those dull aches, the unmyelinated fibers. Now in perception, this is when the recognition and the interpretation of the pain occurs. There are many ways that the central nervous system structures the networks, and this is included where some of those are the phantom limb of pain applies. Some of the areas of the brain that have previously been receiving those messages, they are readapting now. So that's why they get confused and the patient is having those sensations. This is also where pain threshold and pain tolerance is part of perception. Your pain threshold is the point at which your brain recognizes the stimulus of the pain. Your pain tolerance is the level and the length of time that you can endure the pain. So I hear a bunch of you typing, so I'm going to go over that again. Your pain threshold, that's the level where your brain says, I feel some pain. This isn't good. Your pain tolerance is how the level and how long you can tolerate it. Now your book also gave a really nice example there of some of the emotional connectivity to pain. The difference between your pain tolerance for stubbing your toe or the pain tolerance for a mother donating her kidney. So the emotional experience of doing something for the good of your child, you're going to have a higher pain tolerance. So now we come to modulation. This is the last process. And it involves the changing of the perception of pain. So there are two ways the body does this. And the body does this is amazing. The body does this naturally without any intervention at all. So there's the endogenous analgesia system. And this is the way that your body releases its own endogenous opioids to block your pain impulses and provide you pain relief. Now this is often done through stretching or pressure. So my two examples of this is a woman in labor. If you are in labor, if you naturally go into labor, your body is releasing its own hormones and chemicals to help you modulate that pain. The other example of this is acupuncture. So that is the release of some endorphins to help you manage that pain. Any questions so far? So the next way that the body helps modulate or manage the pain is gate control theory. So hopefully what's going to pop up, and I hope that the volume will work, is a video. And there's an exercise in the video I'd like you to try along with the guy in the video. He talks kind of mellow. He's probably part of a pain management exercise.
I want to go back to that idea of repeat
Can you hear it okay?
exercise. So I want you to
Let's see.
You should be able to control it up here.
Oh, okay.
Let's see. Try it again.
Okay.
I want to go back to that idea of repeat. Show you an exercise.
No, that's what
So what he's asking you to do is bite your bottom lip with your teeth. And also close your fist. Bite harder each time and put up one finger each time. So bite a little harder, harder to a 2, harder to a 3. Bite hardest at a 5. When you get to the 5, shake your hand. Did the pain in your lip go away? Where did that pain go? So, there's 2 sets of nerves that go to your brain. The pain nerve is that small nerve. The motion nerve is that larger one. The gate theory lets that larger impulse go through, so it shut out that smaller pain. So that's what he's saying there, is that the larger nerve impulse gates out the smaller one. So sometimes that's why we have patients get up, move around when they're having pain. You guys all have this on your blackboard, so I encourage you to look at it at your convenience when we're done with this today. But I did it at home and I was like, wow, that's really amazing. So just to reinforce the pain threshold, the stimuli necessary to produce the pain, your pain tolerance, the duration and intensity of pain a person can endure, and then intractable pain. Now this is severe and constant pain that is not curable. And some examples of intractable pain are pain from endometriosis or sciatica. So we've talked about how the pain message travels around. And as you're getting ready to assess patient's pain, and it's a good idea to be familiar where the pain is coming from. So on your slides, if you would please make a note here to call this the origin of pain instead of type of pain. So here we have cutaneous or superficial pain. Anybody want to take a guess of a type of injury that would be cutaneous or superficial? How about a scrape or a burn? Just something light on your skin. The somatic pain would be like a fracture, arthritis, or a sprain. The visceral pain I mentioned before, it's going to be something like in your internal organs, so like menstrual cramps or small bowel obstruction, small bowel pain. Radiating pain. Anybody heard that term before? So this is when pain starts in a location and then it goes somewhere else. Now there's 2 things here. There's radiating and referred. The radiating, it starts in that location and it goes somewhere. The referred is pain that is in a different location from where the genesis of the pain is at. So my example for radiating pain is like heartburn. You guys are all too young to have experienced heartburn, right? The first time you experience it, you're going to think you're dying. So, but your esophageal, you're going to have acids that's traveling up. So you're going to have pain that's traveling up. Now, referred pain, this is maybe your patient that's come in that's experiencing jaw pain, but also some chest pressure. So that is some of those clinical indicators of a myocardial infarction. The phantom pain we've already discussed, and psychogenic pain. Now this is kind of getting into some of that fuzzy, subjective area where it's pain that a patient is perceiving, but maybe it's pain that you're not seeing. But what did we say? We said pain is whatever the patient says it is. So I'm going to tell you that several years ago, I was having some horrible abdominal pain for weeks on end that I self-diagnosed as a ovarian cyst. I finally went into the emergency room. I told them that I was having this horrible pain. They worked me up for the ovarian cyst. Couldn't find it. And the emergency room doctor was kind enough to tell me, it's all in your head. I said, then please cut off my head, because it really, really hurts. A CAT scan later, he found out I had kidney stones, which is actually worse than childbirth. So, he judged that I had psychogenic pain, even though I did legitimately have a physiological reason to have pain. So here we're back to that neuropathic pain that we talked a little bit about before when we were doing the comparison between the nociceptive and the neuropathic pain. The difference being that the neuropathic pain was the result of damaged or malfunctioning nerves. You're most often going to see this in your diabetic patients. And the nerve damage that they will have is painful, but it's also going to cause them to be unaware that they may have an injury on their foot. So they may have pain, but then they may also not be able to sense that they have injured their foot. So it's kind of a double-edged sword there. The damaged nerves may also play a factor in that phantom limb pain. And now I've also mentioned here patients with spinal cord injuries. Now there's a medical condition that you're going to learn about later, but I want you to be aware that even patients with spinal cord injuries should be assessed for pain. Neuropathic pain is chronic in nature, and it's usually described as that burning, that pins and needles is what their patients are usually going to say, or that shooting pain. So now that you know a little bit more about the pain process, let's talk about the characteristics of pain. And this is going to help you when you go to assess your patient's pain. We're going to talk about location, the duration, the intensity, and again where that pain's coming from, the etiology. So one of the most important things to document about a patient's pain is the location. Where does it hurt? On this slide are some of the many locations of pain for a headache. Just simply saying, I have a headache, doesn't really help. A headache can be a lot of different things, and it can be in a lot of different locations. You may have a patient that says, I have a migraine. But when they tell you where it hurts, the answer may not be the typical migraine location. So documenting that location helps your assessment, it helps your intervention, and it's going to help your evaluation later on. Another good thing to ask them is, does it radiate, like we were talking about earlier? Does it go anywhere else? So we talked about this a little bit earlier, the referred pain. These are some of the locations, and this is a really good reference for you for later. Some of the points on here are going to be, this is what the pain is, and this is where they're also going to complain of it. Now, the one that I have seen for sure in my practice is a person complaining of the scapular pain that's having gallstones issues. So nowhere near their gallbladder, but they're having that upper shoulder pain.
Think about your heart too, right? What's the classic symptom of someone having a heart attack? Where do they have the pain?
Left arm.
Left arm, right? So radiates down the left arm.
So here we're going to talk a little bit about duration. This is another piece of information that you're going to need. So, can anybody give me an example of acute pain? Probably look here and see. She's got tooth pain, acute pain, and then the chronic pain, low back pain. Boy, low back pain is a chronic pain. For acute pain, the American Pain Society defines acute pain as lasting up to 6 months. It is most commonly associated with injury or surgery. Now, the physical response to acute pain is the increased heart rate, increased respiratory rate, increased blood pressure. You might also get somebody that's like sweaty and clammy. Think about the last time that you were really in pain. Kind of broke out into sweat in the back of your neck. This is an activation of the sympathetic nervous system. Now, what are some of the other things that you might see? It's a short duration again in the acute pain, but some of the pain behaviors. These are some of the things you see. You see him pacing. See him moaning, ooh, crying, grimacing, guarding. That's a really big one, especially in the little kids. Don't touch my bobo. Then we contrast that with the chronic pain. Also can range in severity from mild to severe, intermittent to continuous pain, but it lasts 6 months or longer. Some of the more common diagnoses in the chronic pain category are the low back pain, fibromyalgia, and again the diabetic neuropathy. Now at this point, the sympathetic nervous system is done. It has been overloaded with the noxious stimuli, and it has tuned it out. So parasympathetic takes over. And the larger issue here is fatigue and the decrease in the quality of life. Now, many times these patients have depression, especially in some of the illnesses like fibromyalgia, where you don't look ill, no one knows that you're in pain, but you're in a constant state of pain. All right, so a little bit of humor here. Gotta wake you guys up. So please rate your pain on a 0 to 10 scale, 0 being no pain, 10 being I just force fed you live scorpions, then ripped off both of your arms. This is to help you put a frame of reference. The 0 to 10 scale is the most common scale that we use when we ask our patients to rate their pain. If you just go up to them and say, could you rate your pain on a scale of 0 to 10? They really don't have a frame of reference for that. Most often in my practice, I will say to them, could you please rate your pain for me? 0 being no pain, and 10 being the worst pain of your entire life. Now you'll get people that say 11 or 20 or 1,000,000. 10 is the highest you can go. Please don't document 11. This is some factors that I mentioned before about pain tolerance and pain threshold. And these are some of the things that affect how that physical, that emotional response is going to be. Now, if you're their nurse, think about if you walk in there and you are empathetic to their pain or not. If you kind of brush aside, you're just not, you're not being, you know, strong. It's just a bug bite. It's just a sprain. Suck it up. You know, is that a helpful attitude to their pain? No. You may think it. Try not to emulate. So the attitude of the nurse is important. So don't minimize their feelings. Again, pain is what they say it is. Now, a person's patient, their ethnic and their cultural background is going to impact how they perceive the pain. Their family is going to be there, and their past pain experiences. Especially someone with a chronic illness, someone who comes in for something multiple times, they're going to relate, oh no, here we go again. I've broken bones before. The last time I was in here, it took forever. I had to be in a cast. I don't want to go through this again. So they've built up in their mind that expectation, and their perception is going to meet that reality. So their previous experiences really drive how their experience is going to be. Another thing that frames their response to pain is their age and their developmental stage, and then their environment and their support people. So think about, again, the laboring mom, if she has a supportive doula or if she has a supportive partner that's there with her to help her through that process. So the body responds to pain in both physiological and the psychosocial ways. We've talked about the pain process, and we've mentioned several of these items before, but it's important for you to see them here in the context that these may be things that you observe in a patient that's not reporting pain to you. So if you see some of these things, it might be time to investigate if they are not telling you that they're having pain. So if you start to see that their blood pressure and their pulse is going up, if you see a change in their breathing pattern, if you see that they are withdrawing and guarding, if you tend to notice that they are not sleeping so well anymore, that they've been pushing away their food, you might want to say, how is your pain? Are you having pain? So that's why I wanted you to see this in that context here. Any questions about that? So now why wouldn't they tell you they were having pain? Any guesses?
They don't want to become addicted to painkillers.
Very true, very true. So, a lot of people think that they will become addicted to pain medication after one dose. There is the possibility of chemical dependence, and there is the possible of psychological dependence. Most of the time, this does not happen in the acute care setting, so it's important for you to address that with your patients and let them know. Pain medication prescribed for you in the hospital is important, and we will address your needs as you are here. But they believe that pain is expected. I'm here, I've had surgery, shouldn't I have pain? Maybe they don't want to complain. They don't want to bother the nurse. A lot of them are afraid of the way that they're going to get pain medication. They only think that they're going to get a big shot in the behind. Some people will think that they are weak if they have to ask for pain medication, or pain could mean that something else is wrong. If they're having pain, didn't I have surgery to fix this? Why am I still having pain? That must mean that something went wrong, and I must need more tests and more medicine, and more things are wrong with me. They may also be unable to communicate these needs to you. And then some people feel that enduring pain is a spiritual experience. So this brings us to the nursing process. Yay! Now you've had your first day of clinical, and everyone survived. And now it's time to put your skills to work. So I said at the beginning that pain is considered a vital sign, so it's something that we assess. So how do we assess pain? So there are the nonverbal cues that we talked about, the grimacing, the guarding. There are the vital sign changes that we mentioned, increasing of the heart rate, increasing of the blood pressure. And then we have some pain assessment tools. Have you guys seen this? Yep. So these are the Wong-Baker faces. I've actually even seen this with the Lego heads too, and some pediatric units. They are a combination of the pictures and the numbers, and it's appropriate to use this scale for ages 3 and above. I've seen this up in some hospital inpatient rooms for the nurses to just point it out and say, hey, where do you feel like you're at? So, hope this kind of should. Can you guys see that okay? Well, you got it on your Blackboard site too. So a few slides ago I showed you the 1 to 10 with a little humor attached to it, but it's important that you do put a frame of reference on that 1 to 10 scale, and this Mankowski does a really good job of that. On the side here, I don't know if you can see this, this says a good day, this says average pain level, or sometimes around here, and this says frequent spikes up to here. This is really good about showing you what is a 4. A 4 is, I can ignore it, but if I'm distracted by work, and some mild painkillers will work for about 3 to 4 hours. This is good about a 7. I can barely concentrate. It interferes with my sleep. I can function, but it takes a lot of effort, and I have to take something narcotic. The difference between the 4 and the 7, you might see that the patient is having the same pain level, but at night it'll be different. At night, when they're not distracted by anything, they may say, oh, now it's a 7 because I'm not distracted by anything and now I can't sleep. So you may notice that at night your patients require a little bit more pain support than they do during the day when they're up, active, and easily distracted. And part of the history that you can gather from your patient is any previous treatments that they have used. So prior to seeking treatment, they may have tried some home remedies, and you can ask them, were they effective? You can ask them what medications they used, anything over the counter. This is where always we need to be asking the patients if they tried any herbal supplements over the counter, what did they take, and any non-pharmacological treatments like ice or heat. And this is also where you assess too their allergies and not just their medication allergies. This is an acronym that probably Professor Hanifin used when she was seeing patients in her practice that I know a lot of nurse practitioners use. It's called OLCARTS. And it might help you in remembering how to assess the different parts of what a person's pain is. So the O is for onset. When does the pain happen? L for location. D for duration. C is that character. A is aggravating. What makes the pain worse? R, relieving. What makes the pain better? Does getting up and walking around make your sciatic pain better? Does taking the aspirin make it better? Does putting ice on it make it better? The timing of it. Are you noticing that you have that plantar fasciitis pain more when you first wake up in the morning, and the severity, that 0 to 10 rating. So I'm going to do one more and then I'll give you guys a break. Now the pain diary, this is more for patients with chronic pain. This can help them keep track of their pain at home to bring in and discuss with their provider. This is also talking about how for them to keep track and notice any trends. Do they notice the pain more in the morning, more in the evening after they've been active all day? Their activity or situation. Maybe they shouldn't be running. Maybe they should try some more low intensity exercises. The physical pain character, the quality and intensity, and do they notice any emotions when they're having that pain? As you guys know, sometimes with the myocardial infarction, sometimes emotions will bring that on too. And then the meds and any pain relief that they use. Any questions before we take a break? Okay. 10 minutes? Okay.
Did you guys get, what do you call it? Survey about if you had a laptop? It looks like everybody has a laptop. Anybody not use a laptop to take notes in class? No, everybody in the class has a laptop. That was just a survey we're just trying to do, thinking about, next semester with, asking students to use their own laptop for ExamSoft. Just wondering.
What if you don't trust your computer to like maintain being on during?
Yeah, but you don't, you all have chargers, okay, you charge?
No, but my computer sometimes just like turns off.
I'd rather go to a lab, like
Yeah.
a computer lab, even though I have one.
Yeah,
Yeah.
just don't.
Oh, I like the computer lab too, the problem is we just don't have enough space for everybody to use it. So anyways, just a survey, we just wanted to
Yeah, I
see.
don't want it to.
But that's good feedback to have, that you don't trust your own laptops because they're too old.
Or I mean, like, it just sucks.
Just, if it's the school computer and they're there and they know, I'd rather be on my
Honestly,
It's like everyone's had their like Blackboard quiz, like during, I had one time on my computer.
But the thing is, so, I'm thinking, we have the computers, you'd have to come in with a full charge, and you'd have to, ignore any upgrades. You know how sometimes it says, yeah, you'd have to either make sure you did those the night before, or ignore them before the exam, so that you could use it.
it's just
No, this is not for this semester.
I like
Just
to
trying
talk
just trying to move forward for next semester.
where I
We
wrote
have
something.
more availability for computer space, but it seems like every student takes notes. I mean, you're the only one not taking notes on laptop.
Yeah. I have mine, but it just turns off sometimes.
Yeah, no, that's fine, but just,
There's
again.
like no chargers in this building.
Yeah, that's
So
the other
like
thing.
no outlets.
Okay, well, Spiro Agnew was governor of Maryland when this building was built. Anybody know what year
No, it's
that
just
was?
sometimes like.
That was the mid-1950s. So that's how old this building is. So, right, so, what's that? Well, outlets were a thing, but there wasn't, really, they were just for lights. There's nothing else that they really needed to do. But so trying to figure out, right, so everything that I'm kind of coming up with has its own set of folks that need to support it. Like you said, electricity, Wi-Fi access.
That's
if
the
I-
other thing, on my computer, like the Wi-Fi just disconnects
Yeah.
sometimes, and so.
Right,
that
so I
never
need to,
happens when
I need
use
to get
the
that
school one.
supported, so that's
Yeah.
paying for that. Plus then we need to, we're thinking about, a cart where we would wheel out the computers, but that support of someone making sure they're charged the night before and making sure that all those upgrades happen. The fact is, we just don't have enough computer lab space, hardwired computers to do this. But I really think we have to move towards the full online testing, because that's what you're gonna get in NCLEX.
And I don't think you would need to get like an entire, like mobile computer a lot, but I can announce that, like, if they are uncomfortable with their laptops, have the option of using it.
Yeah,
that's true.
what I'm
So,
thinking
like,
too.
10 to 15 computers.
There's not
Just
enough.
makes me so nervous that it would like disconnect from Wi-Fi.
I know, and then I'm,
As of
We take
fall of
one-
19.
Would it everyone be at the
Yes.
same time?
Laptops.
yep,
But,
yeah.
yeah. Department of Education.
I do better on the
Yeah, so, yeah, as of fall of 19, you have to have a laptop. And they're not supporting Mac.
Oh my god,
See, that's the other issue.
that.
Yeah.
No, we're not saying not supporting Mac, we
Oh,
have to support Mac.
oh,
But Maryland will not allow Mac for the, in the nursing program.
Oh,
So
university.
if you just graduated high school and your parents bought you a brand new Mac,
Wait, this is university.
well, you'd know going in, right? So when so in their admissions information, it's gonna say, you have to have these specifications, you can't.
Wow, that's crazy.
I think Macs are the devil. I don't like them. I think they're evil. I think it's like a thing. We have a big hardwire.
It's so
family,
dangerous.
and I said, no, I can't.
I don't know.
Not figure out how to build that. I can't do anything. I've just been accused of it since 2009. Let's go to the draft.
And then you get
But I can't get it on the folder. I wanted to.
And I know one of the like, yeah.
Oh, drag it into the trash.
She's really empty out your trash. What?
Because I was just accused of all kinds of junk.
I was just looking over them, they're good.
I know it's a hard.
Rebecca's. Can I make sure that I actually have Yeah, so she's gonna send them those like right today. So when is she?
on the main slide.
I wouldn't read the blurb on the main slide, it's like, mainly affects females, and I'm like,
So just remember showing hands, how many would trust taking, using their own computer to take an exam, their own laptop?
Yeah, but like,
Maybe if you guys,
I don't know.
is there a way for you guys to install more outlets into the building?
Well, not me personally.
Yeah, if I have my computer plugged in,
But
you're
you're
seeing the
seeing
front row a lot.
Actually,
Yeah.
sometimes
I bring it in my
Okay, that's good to know. That's, it's all good feedback, guys, we're just trying to figure out what's going on going forward.
Get a bunch of it. So especially like on days
Well,
like
that's what I'm
tonight.
thinking.
My
But
computer
then I
is
also
rapidly
have to
dying as we're
support the
speaking, I have no
Wi-Fi.
outlet.
We had 3 classes.
Like for example, when I got here, my computer was that, I'm not even on the internet, I'm simply on PowerPoint, I came here at 50% in the morning down to 30. My computer went down last night.
Just disconnect for no reason.
Oh, no, like,
Well, there's TU Secure, and I think that's a lot.
So is it worse, guys, is it worse in this building than other buildings?
I've only ever had shooting.
No, but I think also.
honestly, the worst
people don't get
question
off
to be
TU
asked.
Secure.
Oh, yeah, you have to
When
have
when
TU
people ask
Secure.
TU my opinions, like, I'm like,
Either.
you know, it's like hard.
It wasn't mine.
It is cut out. And I actually enjoy being here on I was almost this morning, like, mad.
Also like,
Yeah, no, without stuff I need to hear.
He didn't even teach.
You said it, and I heard what we had said.
It was like, I was like,
So was I right at the end of that meeting, listing all the things? I'm like, people, something needs to step up.
it should be easy.
All day long, all I heard is, what's Nancy gonna do? What's Nancy gonna do?
It's
Where's
like
Nancy?
first. We're talking about this too, like that. Their computer. Was it long? I was telling him, I'm like, oh, I gotta. No, because it was like a note taker, and then we did have done. So.
Oh, no, I think they printed next to it.
Okay. So,
like if you're getting.
they have down there. And don't, they just put a shelf. They don't put like exactly what
Oh, yeah.
not really. I just. Oh, you went last time.
Because you're engaged in it, yeah. I know, but the problem is, they've been doing this for so long to take that away.
I feel like it just me, and I was like,
Since my daughter was in the 6th grade, her laptop was required. She does everything. My son was not that way, but my daughter did everything. She does now. Now she's doing college. She didn't have to let you, she could just go. But yeah, since the 6th grade, she's required. And a certain amount of time. But you're doing great. Just keep relating it back to the nursing process and caring for them, because that's what they really, that's what they do.
Oh, I see, okay. Yeah, I just figured out the contact.
Which I didn't know under their program.
Yeah.
And you're doing PCA and stuff?
I saw it just like
All right, one more announcement, guys. I know you're still in break mode, but one more thing. So exam 3 is the Monday after Easter and what's it called? Oh, I'm blanking. Passover. Sorry, terrible. I teach cultural diversity and I couldn't even come up with the word Passover. So anyway, so because it's that Monday, and I know some folks want to travel home with their families, we're going to offer the exam on Thursday evening, the Thursday before, not the Thursday after. So what is that? The 18th? I can't remember that date. I'll look at my calendar.
Yes, it's the 18th.
Okay, so you guys are in clinical, so at 4 o'clock. You do not have to take it at that time. You certainly can take it on the Monday at the regular time, because you're going to have all day to study anyway. But folks were concerned that you had a patho exam, but now I know you have a physical assessment exam anyway the week before. So there's nothing I can do about moving exams that they're not going to overlap with somebody else. So what I'm going to give you is 2 options: 4 o'clock on Thursday, or the regular standard we had planned for the 22nd. So you have all weekend to study. It's heavy duty, there's a lot of material, so I'm going to be lecturing Monday, and that's on the exam on Thursday. So if you think you're going to have the time, plus preparing for 347, that's your decision. If you don't do well, there's nothing I can do about it. You took the exam. So, so you really need to consider how much time you're going to need to prepare for that exam, and you have and you can't miss clinical. If you miss clinical, you can't take the exam. Let me just make that perfectly clear, okay? Because if you're out of clinical, then you should not be sitting for an exam. So. In the computer lab. Yeah, in the computer lab. And I'll put out an announcement, but I just, what's that?
I'm probably going to.
Are we gonna let you know in advance, or do you just show?
No, I want you to let me know in advance, but I'm going to put out a list so that you can make something more formal. So because I only have so many spots in that computer lab anyway. So we're offering it to obviously Professor Wilson's class as well. Right, then you have all weekends. You have Friday. Friday's going to be a slow day. It's Good Friday, Saturday, Sunday. People are going home, so they're not out. There won't be much nightlife here on campus, right? So you might just, right, so you can put the time into doing it, right, and doing well. Okie doke. All right, we're gonna get started again, right? All right, guys, you ready to get started again?
Okay, so we made it through the assessment part of the nursing process. Now we're going to move on to the special populations and pain and the special populations and then age groups. So I have this quote up here. The